Hello everybody and welcome to this Click and Chat special part 2 on nephrectomies. I'm joined again by Steve Leung from Edinburgh Hospital. Those of you that have watched the first section I'm sure will have found it invaluable, and we certainly have very positive feedback from that. So once again, thank you Steve for part 1 and thank you for coming back for part 2. No problem. When we spoke last time, we were discussing the actual surgery part of a nephrectomy and what the process was, how you decide between full and partial nephrectomies and decision making really before operation. So I suppose in the next stage really is the after a nephrectomy. What is the process that a patient would be expected to follow? What would they do? What would happen to the kidney? What tests are carried out? And the procedures really following immediately following that nephrectomy?
Yeah, the standard procedure, I think, for any patient after they've had a surgery, whether it's open, partial, laparoscopic nephrectomy, would be a period of recovery, and they'll have their kind of post-operative recovery in hospital, supported by the nursing team and the surgeons. And when they get home, then what we would schedule would be a kind of follow-up appointment for the patients. And usually that's kind of carried out by the operating surgeon, that they're listed for an appointment in the outpatient clinic to discuss the results from the tumour that has been removed. And these results can be termed the pathology results or the histology results. So these are the kind of technical terms given to the information we get from when we remove the tumor and send it off to the pathology lab to be examined under the microscope. And this is a very key point in the pathway of the patient, because then it allows us as the surgical team to know exactly what type of cancer or tumor that we have removed from the patient. And when we do see the patients back again after a period of time, usually 4 to 6 weeks, then a part of that consultation will be to talk to the patient about how their post-operative recovery has been during that time. Has there been any issues with the surgical wounds? Has there been any issues with general recovery from the procedure? And then it's really focusing on what the pathology or histology results mean. And what we do, certainly in Edinburgh, is that we have a detailed report from the pathologist, and we use this to then guide what follow-up treatment that the patient requires. And it may not be just treatment, it's maybe just surveillance. And so for a lot of our patients, it is a period of protocolized or defined surveillance. And that usually is regular blood tests and regular scans. And the way we use the pathology result or the histology result is that it allows a degree of kind of looking into the future, what the prognosis would be, following that operation. And also we use that pathology information to then allow us to tailor the type of surveillance that that patient needs. So for example, for clear cell renal cell cancer, so the most common type of kidney cancer, we have what we call a Leibovitz score provided by the pathologist. And we use that Leibovitz score to then almost risk stratify that patient to low risk or intermediate risk or high risk. And what that means to us as surgeons is that risk of the cancer recurring. And if you're in the high risk group, we then do slightly more scans within that 5-year period, compared to if they're low risk, then we do maybe a less intensive scan. So it allows us to give the patient an idea of what to expect in the future.
Great, and really, really helpful information. Something I wondered, you mentioned there, pathology, histology report. One thing we see on the forum and get asked a lot is about biopsies. So what is the difference between a pathology or histology report or a biopsy test and report?
What a biopsy normally means to a surgeon is a test that we organize to take a sample of a tumor. And so if you were undergoing a biopsy, then to most surgeons, that would mean that you're sampling that tumor. And the scenarios whereby we might do a biopsy would be if we were considering, say, treatment for a small kidney tumor. We want to work out what the actual cells that are contained in that small tumor might be, and that would then allow us to say, is it a malignant lesion or a non-malignant lesion? Perhaps if you've got metastatic disease, so there's cancer that has spread out with the kidney, then we tend to use a biopsy to then inform the oncologist as to what type of treatment would be most suitable for that patient. So for a surgeon or for clinicians, a biopsy is something that we use to get more diagnostic information before actually instigating management. But how biopsy and histology and pathology linking together, all these technical terms, is that a biopsy provides us with histological information. And so a biopsy would be to take some samples and some cellular material from the tumor, and the same process, we send it off to the pathology department, who then look at it under a microscope, and then they give us the histological or pathological information about that sample.
That's great. So just for layman's clarification, really, biopsy in normal terms is pre-operation. Histology, pathology is post-operation.
That's usually how you would use these terms, exactly, yeah. If you're saying to a patient, you're going for a biopsy first, then that suggests that the clinician is organizing a test which then takes samples from that patient, and that guides further treatment. And then if, say, you've had your operation or your treatment and you say, look, we'll bring you back in 4 to 6 weeks' time to talk about the histology or the pathology, then what that clinician is saying to you is that, look, we've taken away the tumor, we're going to send that off to the lab and get that information back from the lab, and we're going to talk about the pathology or histology.
Perfect. Two sort of questions in one, really, and it relates to something you've just mentioned or touched on in terms of metatasis of the cancer. Now, I'll let you explain exactly what that word means, often shorted down to METs. But I'm aware, but for others, why would a patient not be offered a nephrectomy? It's along the lines of, if you already have METs, I know. And I know you've mentioned that it's quite a topical, or we've discussed it's quite a topical thing at the moment, of what then needs to happen for a nephrectomy to then be subsequently allowed in the future.
In the setting of metastatic kidney cancer, what that means is that that cancer has spread outside the kidney to other areas of the body. So it's then a situation where that cancer has spread. And so in many other diseases, removing the primary tumor, removing the origin of the disease, which is the kidney. In kidney cancer, this is something that we have seen benefit for in patients. And the basis of this was studies maybe about 20 years ago in what we call the interferon era. And interferon is a treatment that stimulates the immune response to help fight cancer. And this was the treatment that was available for kidney cancer patients about 2 decades ago. And what we found in those studies in that era was that if you remove the primary kidney tumor, and give them interferon treatment or systemic treatment, which means treatment that works within the whole body, then those patients would have a better overall survival than just giving the systemic treatment of interferon. And so in kidney cancer, in the setting of metastatic disease, kidney surgeons still had a role in removing kidneys that unfortunately the disease had spread out with the kidney. Now, when we fast forward to the current situation now, we've now had targeted therapies such as tyrosine kinase inhibitors or TKIs, but now we're moving into the next era of immunotherapy, the newer agents, and the so-called immune checkpoint inhibitors. And so that finding of doing a nephrectomy in the context of metastatic disease has been recently investigated by two randomized controlled trials. And these trials are called Carmina and Surtime. And they've asked the question, in the TKI era, so in the last 10 years or so, is it right still to offer a nephrectomy when patients have got metastatic disease? And what these studies have shown is that the evidence is still not clear as to which patients benefit the most from having a nephrectomy upfront. So right at the beginning, you remove their tumor, or should they go for systemic therapy first? Should they go for, treatment under the care of the oncologist first? And what we've seen is that we've seen some evidence from these two trials to give us a steer as to what patients would benefit from having a nephrectomy upfront and not having a nephrectomy upfront. And some of the guidance out there, and again, it's, there's a lot of research into this area, suggests that for the patients who have symptoms, if they've got pain, bleeding from their disease, and they are of a good performance status. So what that means is that they are, relatively fit to undergo a major procedure, then these patients who have symptoms may benefit from actually having their kidney removed, because dealing with pain, bleeding in their urine, these are symptoms that can compromise the patient's quality of life. For patients who are asymptomatic, so they don't have any symptoms, but they do have metastatic disease, then these are some of the patients that may benefit from having what we call upfront systemic therapy. So we would say, look, you may benefit from having systemic treatment that treats not just the kidney tumor, but the disease that's spread outside the kidney first. And then, if you have a good response from that, then in discussion with the oncology team and the surgical team, we may offer what we call a deferred cytoreductive nephrectomy. And that technical term of cytoreductive nephrectomy means that we're doing a nephrectomy to remove the bulk of the disease, but in the setting of metastatic disease. So even though you may have a diagnosis of metastatic kidney cancer, and the team say, look, I think it's best not to have a nephrectomy first of all, but to go for systemic therapy, then we don't close the door on offering you surgery. But again, it involves very close collaboration and working with our oncology colleagues, and it's all very individual and patient decision.
Really interesting stuff, and obviously trials and tests and research is coming on all the time, and informing these sort of decisions, as you say. From a surgeon's point of view, how do you find patients react when they are told nephrectomies are going to be deferred or not possible at this stage, because one can only imagine, as somebody who's just been told they've got cancer in their kidney and there's a surgical option, it's a no-brainer really for that person to think, well, that is coming out and that's got to come out. How do you combat that as a surgeon?
Yeah, I think it is a very challenging situation, Steve. Indeed, you've got a patient there who has a kidney tumor, but unfortunately it's spread. Devastating news for the patient. And the patient naturally would say, well, is there not a surgical option? Can you not remove the kidney? And I think it is to be able to communicate these difficult decisions and the thinking behind these decisions, the evidence behind these decisions clearly to the patient. And I think this is where not just having the surgeon deliver this news, but also having the support of the team, the cancer nurse specialists, but most importantly as well is having close relationship with working relationships with your oncology colleagues. And I think this is where this group of patients who have metastatic kidney cancer benefit the most, when you have not just the surgeon and the surgical team, but also the oncology team working hand in hand. Because yes, it's a very interesting area where there's still new evidence to be generated. There's still no clear guidance and evidence in terms of who to select for upfront cytoreductive nephrectomy, or who should have deferred nephrectomy. So it's ensuring that that team, that kidney cancer team, are aware of all the different aspects of the patient's disease. So it's the patient factors, the tumor factors, and also the results that we look at, things we call prognostic markers, that then enable us to make the right decision for that patient.
Yeah, really interesting. And as we said, it must be so hard for a patient at that point, but I think you're right. And as a former patient, I understand if you're given the right information in the right way from a collection of people, then it helps with the understanding, definitely. Just a couple of times you've mentioned the difference between a surgeon and an oncologist and the CNS. Could you just explain the difference between a urologist, an oncologist, CNS? What is that? As we come to an end, just because the next sort of video in the series will be with a CNS and their role in this.
Yeah, and the surgeon, as the name suggests, is the person that practices surgery to remove tumors. And usually the renal cancer surgeon is the first clinician that a patient sees when they have a diagnosis of a kidney tumor or kidney cancer. And in certainly my institution, even if you have metastatic kidney cancer, so cancer that's spread out with the kidney, we as surgeons would see that patient first to describe the disease and to inform that patient of their diagnosis. Our team is supported by our cancer nurse specialist, the CNS. And this CNS is a person who is skilled in dealing with cancer, and they support the surgeons in delivering that news to the patient. And certainly in my institution, we would then introduce the patient to our CNS, who's called Lisa. And Lisa would be that first point of call and contact for that patient. And I think that gives patients a real sense of security and knowing that they've got somebody to call who knows their diagnosis really well, and who can offer advice and guidance and act as a kind of a go-between between other clinicians. Then the other big group of clinicians are the oncologists, and these are non-surgeons, but they are clinicians who are skilled at managing systemic therapies. So what I mean by systemic therapies are chemotherapy agents or medications that help patients with cancer that that need some form of systemic or whole body treatment. And again, they're very important in managing patients who've got, metastatic disease.
Excellent. Excellent. So just one final question. For those who have a nephrectomy and have no metastasis occurrence, who would follow up their care other than the CNS when they have their regular scans on however long it's been determined as a result of their histology? Who would follow them up? Would that then be back to the surgeon? Would they stay under them?
Yeah, I think practice varies throughout the country, and I think we've been very fortunate to have a CNS in our institution, and we've developed strong protocols in how patients are followed up after their nephrectomy. And a lot of these protocols allow the CNS to then manage the surveillance and follow-up for these patients. In other areas, it may come down to the surgeon, who then calls these patients back to their clinic for the regular scans and blood tests as well. So the practice varies, but I think certainly our CNS plays a real central role in supporting the patients even 2, 3, 4 years out from their surgery in terms of managing their surveillance scans.
Perfect. Steve, thank you very much once again for your time. It is absolutely invaluable. We know the pressures that you guys are under at the moment, so we really do appreciate you taking the time to talk to us today and last time, and for the work that you continue to do with Kidney Cancer Support Network.
Yeah, well, thank you for the opportunity to speak to everyone today.